Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
There's a few changes in here that are really tasty that we can chat about. Disclosures or my disclaimers is that as of today, December 12th, 2024, that what we have approved by the U.S. Food and Drug Administration is FTC TDF, which is brand name Truvada, available as brand name and generic, approved for daily use. FTC TAF, which is brand name Descovy, approved for daily use. And injectable long-acting cabotegravir, which is brand name Apretude. They are approved for some, but not all populations. I always say what day of the talk, because these things are still changing so quickly that as of today, this is true, but we're probably going to talk about things that are, in fact, I know we're going to talk about things that are not yet FDA approved, including lenacapavir, which is FDA approved for HIV treatment, but not as HIV prevention yet. And then we'll talk, I'm sure, about some of these non-FDA approved strategies. This is the standard disclaimer. And I just want to touch on this rating scales that are being used in IAS-USA. I don't know if these have always been the same, but one of the things that I notice, the ABC is still, I believe, the same, strong, moderate, or limited support. But the quality of evidence now includes a distinction in the A or B level, whether or not your randomized clinical trial, which is a 1, is published, an A, 1A, or was just presented at a scientific meeting. And I don't know if this is new for this guidelines or if this has always been true. I'm looking at you, Brian. You're shaking your head. Sorry.
Also not totally sure, to be honest.
Yeah, so interesting, but this will become relevant as we move in. These guidelines, again, as Brian mentioned, have a section. I am not going through this slide. This is just the long and short of it if you want to just understand what the current guidelines are. Again, this is from the International AIDS Society. This is distinct recommendations and not the HHS-CDC. So these recommendations, again, for HIV medicines as prevention, you can read this square and you'll know pretty much everything that they're going to say. But we're going to go into a little more details in the next 10, 15 minutes. I've done this talk before comparing what our guidelines are. And I actually, in thinking about this, thought it was most useful to look at where things were and where things are in our current guidelines. So you're going to see the newest guidelines in the left box compared to when there are changes, the IAS-USA guidelines from their most recent recommendations, which were 2022. And then in the far right are the 2021 HHS guidelines, which we know are an update is coming, but have been delayed because of Dawn Smith's unfortunate death in the last year. So maybe we'll see those updates in 2025. I'm not optimistic, but we know that they're coming. So this slide is looking at who should be prescribed PrEP. And one of the things you'll see when we compare HHS and CDC is that the HHS CDC guidelines are generally more prescriptive in terms of what and who and how PrEP should be prescribed, whereas the IAS-USA guidelines starting in 2022 became more liberal in terms of their recommendation. And then in 2024, become even more so. And so in 2022, we saw them say, we shouldn't even be using risk criteria to talk about PrEP. Everybody should have a conversation about PrEP and encouraged. And they should be particularly encouraged if they fall in what are certain risk categories, which you can see in the middle from 2022. And then over on the left are the most recent guidelines. So basically, people who we consider to be populations that have higher HIV incidence and prevalence, so folks who are LGBTQ+, folks who are young, folks with from high incidence, people who report transactional sex for money drugs, etc., people who inject drugs, patients who are incarcerated, or patients who have partners who are incarcerated, and anyone who's had an STI in the past year. That is who should be prescribed PrEP, what to prescribe. This hasn't changed really between 2021 and the most recent IAS guidelines. Everyone is recommended to start on FTC-TDF. FTC-TAF is recommended for folks who have limited renal function or osteoporosis. In 2024, the IAS-USA guidelines add osteopenia to that and basically continue to say that it should be offered only to folks who are not at risk. FTC-TAF should not be prescribed for anyone who is at risk from HIV through vaginal or neovaginal sex. This is interesting that they've stated this at this time because it's my understanding that the company who makes FTC-TAF is moving forward with their FDA application to expand the indication to include people who are at risk for vaginal or neovaginal sex. So it will be interesting to see what the FDA does with all of that. Obviously, the FDA does not look at these recommendations, but I thought it was interesting that they explicitly made this statement in the guidelines, right, as we know that they're moving forward with that. And then that they continue to say that injectable cabotegravir, even though it's only been studied for sexual risks, should be available to people who inject drugs, but who also have sexual risks, even though it's not been studied in that population. And then the statement that the best PrEP regimen for a person is the one that is really consistent with what they are looking for, the potential exposures, the ability to take their medicines, and their ability to plan on their activity and their concerns for different risks and side effects. 211 dosing also had a few changes from the previous CDC guidelines. They are very explicit that they recommend it only for adult cisgender men who have sex with men who have infrequent sex and can anticipate sex. The 2022 IAS-USA guidelines were broader than that and recommended with caution in transgender women who were receiving hormone therapy. Recommended without issue for folks who were not on hormone therapy. And then there are some additional recommendations in 2024. They echo that it's recommended for cisgender men. They actually recommended it for other populations who are at risk from HIV having receptive anal intercourse and can plan that. They make a comment that folks who are transgender women on the hormone therapy should take their pills with food, and again, comment on insufficient data in other populations. I've always found that this is an interesting question where people are making recommendations with not a lot of absolutely clear data. The initial HHS recommendations comment on the time to maximal levels, which we know in rectal tissue is a week, and in blood and cervical vaginal tissues is about 3 weeks, but don't say when someone has received adequate dosing in order to feel fully protected. The IAS-USA guidelines have come out stronger in this, and in 2022 said that all cisgender men who have sex with men should start their oral PrEP with 2 pills, and then they are fully protected within 24 hours, and that everyone else should take 7 days. They are now saying that everybody starting oral FTC-TDF should take that initial 2-pill dose. And then in terms of thinking about how long someone needs to take their PrEP, their daily PrEP after their last exposure, I always say that if you're super conservative, that you should continue a full PEP dose, although that's probably more than anybody needs to take. But they explicitly say that cisgender men should take it only 2 days after their last exposure, and everybody else only needs 7 days. So more guidance, perhaps, than the data are clear for. But it's really CAB where we start to get some interesting recommendations. So a lot of changes here. One is related to oral medicines before starting CAB. So it's always been optional for folks who are starting injectable cabotegravir to start with a oral dose, the idea being that it's easier to stop pills than a long-acting injection. So in other guidance, it's really been about people who had serious concerns or severe atopic history. They are actually coming out more strongly for a oral lead-in, and in particular, if someone is on oral PrEP before starting injectable cabotegravir, there's now a recommendation from these guidelines to take 7 days of oral medicine after the first injection, probably because of some concern about we don't know what the time to protection is with CAB, and there's some concern that in the studies that people acquired HIV soon after that first injection. And so overlap for 7 days of oral CAB if someone had started with oral CAB, or oral FTC TDF if they have not been on oral CAB. There's an explicit recommendation to have pills in pocket for folks on injectable cabotegravir in case they have delays in getting back to injections. So giving someone pills who is being prescribed injections, and then a recommendation for restarting that initial 4-week interval. So when someone starts on injectable cabotegravir, after the first injection, the second injection is 4 weeks later, and then it goes to every 2 weeks. There's in here an explicit recommendation to start that 4-week interval if someone misses their last injection window by more than 8 weeks. So a little more guidance around how to manage adherence on cabotegravir. But this is, I think, in terms of thinking about HIV testing, this is where things get really interesting to me. I mean, granted, I love HIV testing, but they make an explicit comment that all of the other testing is the same as in 2022, and you should just look back at the previous guidelines if you have questions about frequency of STI testing and other things. But things are going to get really funny around HIV testing. So going back in CDC HIV, CDC HHS guidelines, the recommendation is to do an HIV test within 7 days of starting PrEP, oral fluid testing not recommended, and for people starting oral PrEP, that they can have an antigen antibody test. Cabotegravir, for people starting injectable cabotegravir, RNA testing is what was recommended. Again, we're just talking about baseline testing. The IAS-USA Guidelines in 2022 basically said similar things, that at baseline, someone should have an antigen antibody test and RNA testing if they are starting CAB. Things get sort of flipped around now with the 2024 guidelines, where antigen antibody testing is recommended, but also HIV RNA testing is recommended for everybody starting PrEP. And if testing is not available, then everybody should have a 1-month follow-up visit for antigen antibody testing. Okay, so RNA testing for everybody at baseline according to these guidelines. And then for monitoring, we all threw up our hands and said, with the new CDC HHS guidelines, which started recommending both antigen antibody testing and RNA testing in follow-up of everyone, people on oral PrEP, people on injectable PrEP. The 2022 IAS-USA guidelines kept RNA testing only for folks on injectable CAB. However, now with these 2024 guidelines, they are not recommending RNA testing and follow-up for anybody, including folks on injectable CAB. And the reason for this, and the comment I made about the study, the 1B, information from randomized clinical trials that's only available in a meeting setting, is that this is based on data that Rafi Landovitz presented from the HPTN study, looking at the people who acquired HIV while receiving injectable cabotegravir. And they did a look back, and I'm not going to walk you through all of these slides, but they looked at who tested positive only using the HIV RNA and whether or not they had a true positive or false positive, and what the consequences of having a positive test were. And I think I have just this slide, which is that of the people who had positive tests, there were 7 who had delays in their next injection, of which the majority of them were false positives. And then when you look at how many false positives, there were 22 false positives and 5 true positives among folks who had only an RNA that was positive. You can see that most of those false positives were relatively low levels, although there was some overlap with some people with true positives having low levels and some people with perceived false positives have levels above 100 copies. It is this data that is why the guidelines now have the recommendations to not do RNA testing, because testing is more likely to be a false positive than a true positive, and because there are delays in those people who are really not infected, there are delays which puts people at risk for acquiring HIV or loss of bulb and all of that. Now, those are what those recommendations are. I'm including here a slide from the package insert for injectable cabotegravir, which says that when you are on injectable cabotegravir, that with each injection, so in follow-up, that you must use a test approved or cleared by the FDA for diagnosis of acute or primary HIV infection. Well, I look at that first part and say, okay, well, antigen antibody testing is actually an FDA-approved test for the diagnosis of acute HIV infection, so you don't necessarily need to do RNA testing according to the package insert. However, the package insert goes on to say that if you have an antigen antibody test that is negative, then those negative results should be followed up with an RNA test. Now, we can talk about whether the package insert reflects the standard of care, and therefore, if there was an adverse outcome and you hadn't done an RNA test and follow-up, whether that would be a problem. I think that's an interesting question about what the package insert means. But right now, there's this tension between what all of our guidelines are saying and what the FDA approval is saying for injectable cabotegravir. Okay, that's really the most exciting part of this and all the controversy. So just quickly, I'm going to run through. There are comments, again, about same-day PrEP. They're no different than they were in previous recommendations, but I include them here for you just to be complete. There is, again, sections on PEP and on PrEP. Again, recommendation if someone has an exposure that warrants PEP or post-exposure prophylaxis is to be seamless with that continuation of PrEP if PrEP is indicated. And I always think that it's really interesting that they've stopped, both the HHS guidelines and the IAS-USA guidelines haven't talked about when PEP is not indicated in someone who is receiving PrEP and adherent. And I think this is helpful as you're thinking about whether or not to start someone on PEP who has been on PrEP, that if they are adherent, that's the whole point of PrEP, that they don't necessarily need that third drug. But I find it interesting that the guidelines have dropped these comments. And then finally, there's a comment about adjusting butane. If someone is on cabotegravir, they mention lenacapavir, which, as I said earlier, is not yet FDA approved for HIV prevention. And then there's an expanded section on both doxypep as well as opioids. So that is the end of my talk. I'm happy to take questions. Thank you very much.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.